This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, welcome to another Owens Recovery Science Podcast. It's been forever, as usual, but all of a sudden, this is our first secure in place lockdown coronavirus podcast. So we're hoping that we're just going to churn out like 100 of these while all of us are stuck at home. We're all working in our underwear currently because no one has to go to work right now. Anyways, I've got Kyle Kimbrell on here from our team, Zach Dunkel and Ben Weatherford. And it's awesome to have everyone together here to get back on the podcast. We're going to speak today about the risk of clots, VTEs, PEs, DVTs, whatever you want to call it, with blood flow restriction, especially because we do this on the clinical patient and we do a lot of it on the post-surgical patient or the post-injured patient. And what is the deep dive literature really say on that, and should you be concerned or not? So, fellas, what's up? First things first. We usually do where you've been, where you're going. Right now, I'm going basically to my mailbox and back. That's about it. I might be going around a zombie apocalypse trying to find toilet paper soon. I'm in a house with 3 women, 1 woman and 2 little kids, and we're rolling through toilet paper like 2 rolls a day right now, baby. It's crazy.
That's a lot.
Yeah, man.
You got to get the SPS of those rolls, Johnny. You got to know the SPS.
Yeah, right. It was Jimmy Kimmel or someone. One of the guys said he goes and buys supplies at CVS because the receipt is long enough. It's a roll of toilet paper for about a week. So I might have
That's
to go.
Very
with
accurate.
Yeah. How's things, man? Everybody hanging in there? Clinics are closing left and right. We're going to have this week, we're going to be interviewing some of our friends around the country who have clinics and going over how they're doing BFR, but also, just kind of talking with them about what the heck's going on right now in this crisis. And Zach, have y'all completely shut down seeing patients? Are you locked down?
By the time this thing airs, we're going to take a 2-week break.
2-week break, yeah. And that's tough. I mean, I know Kyle, we know folks who they basically have had to lay off staff already because of this. So we're feeling for everybody out there, man. This sucks ass. Who knew it would get so bad? I think we had a clue, but so bad on the economy right now is a killer. So yeah, going nowhere. I was supposed to be with the Philadelphia Eagles next week. I was excited to go up there and see that, and they're on lockdown. But past things, just to talk about, we do have some new papers that have come out. Current reviews in musculoskeletal medicine. We did a paper on new technologies for rehabilitation with the United States Olympic team folks, as well as the folks out of University of Colorado, who did everything from how we're using technologies for trauma to sports medicine to the elderly total joint patients. So we have a open access link that we can probably put in our show notes. That if you want to get that, if you click the link, the CRMM gave us the ability to let people get that paper for free. It's going to expire eventually. And then we had a paper come out on blood flow restriction for ACLs in a special journal on ACLs from Aspetar, which is one of the premier sports med groups in the country. And that's still free to get, right? Have you seen, Kyle or Ben? You can just click on and get it. Okay.
Sometimes it's wonky downloading it. But also if people just email us, we can share. But
we can put a link in the show notes. That's a slick journal they put out.
It really is.
Cool
it's
pictures.
Very pleasing to the eye, like the way they put it together.
They do well over their marketing. Yeah. It's got a lot of social buzz as well. We have the APTA instructional course lecture. I just spoke with them yesterday. That should be coming out pretty soon, so people can go to the American Physical Therapy Association and get basically a giant book of the latest kind of information on blood flow restriction. And then
they've discounted their stuff right now too, Johnny. Like I saw a deal from the APTA yesterday, the ortho section, that all those independent study courses are discounted right now. So it's there's a lot of really great content that you can get through that ortho section through those independent study courses.
If you're bored, go on there and support the APTA and everyone else during this time right now. Yeah, and once it gets out, we'll put some social out there. And Dr. Luke Hughes and Dr. Stephen Patterson were on that with us as well. So I think it's really good. And then we're filming tomorrow. We've partnered with the University of Southern California and filming blood flow restriction for their students. And that's going to be filmed remotely. We were going to do it in person and film, but remotely. So trying to help support the students so they can keep learning and get in the introductory kind of training on it. So
I feel like after we film that, Johnny, at least for me, they're going to be like, you know what, Kyle, we can stick to the podcast. You get that radio for face for radio thing going, so we'll see. We'll see if I can deliver.
Well, yeah, you can probably do some sort of filter or something.
I can get like a cardboard and yeah, that'd work. Make that happen. Yeah.
They told us to wear jewel tones. I had no freaking idea what a jewel tone is. So I had to ask them. And so you're supposed to wear clothes that are the color of jewelry, which I pretty much have Batman colors like black and gray.
Yeah. No, so, I don't know many dudes that have jewel toned clothes, which is why it was very nice of the way they put it. Like they were trying to educate both sexes, but the reality was this was all geared towards men. Like most men have no idea.
I have like one green button up St. Patrick's Day outfit. So I might just wear that St. Patrick's Day shirt tomorrow. You gotta wear the hat too. No, you can't just wear the shirt. You guys got any information, anything you want to put out before we jump into blood clots and blood flow restriction? So, okay. So let's jump on into this. This is probably like one of the biggest early questions that I got when we were starting to look at doing this in the Department of Defense. And then when we started talking to people about it a long time ago, is like, yeah, but tourniquets cause blood clots. You're seeing post-operative patients or post-trauma patients. You're causing blood clots with this. And so we'd gone through all these kind of safety analysis with our tourniquet folks. We looked at the tourniquet literature. We looked at the blood flow restriction literature. We looked at the clotting literature. And by the point that we moved it into our patient population, this was like one of the least of our concerns was blood clots. And it still is. But now we kind of want to go down this road of how we came to it. So I think first, let's just talk about the incidents, what the terminology is, VTE versus PE versus DVT, and what those kind of mean. So you guys kind of want to start steering down that path?
Yeah. So, I think one of the things that was interesting to me is the overall incidence rate, looking at some of these papers that are trying to create a rough estimate for the incidence of, a venous thromboembolism or, DVT, PE type of event. One of the estimates that seems to be used pretty consistently is 1 to 2 per 1,000 person years.
Yeah.
And I had to look up what that meant, because I'm like, all right, what does it mean to have 1,000 person years? So essentially it's basically like saying, if you average it out, it's about 1 to 2 events per 1,000 people per year.
Right.
So 0.1 to 0.2% chance of having this happen, which was a little higher than I expected. So it was, something that I think don't really come across a whole lot, or I haven't. So it was kind of surprising to me to see that kind of number just as a general.
On the high end, so an incidence is around 150,000 deaths per year is kind of what I've seen. I think, Kyle, you had one on there that was around 90-something thousand.
Yeah, I had 60,000 deaths in the U.S. per year. So 120 kind of sounds probably in the ballpark, I'd guess.
Yeah, another thing that I saw that was pretty interesting is, it's when they were talking about this in some of the review papers, it's besides heart attack and stroke, hemorrhagic stroke, this is the most common cardiovascular event that they, consider to be of danger of some sort,
Right.
So again, more common than I really gave it credit for.
Yeah. And that's what we were talking about earlier, because I saw a lot of big boom trauma and, when you fracture a bone and you get vascular injury, there's a much higher incidence rate. And so we did see them during the wars more than when I was in the civilian sector. But still really rare. You talk to most therapists and, hey, how many that you've seen, like Zach used the right term, symptomatic DVTs have you seen, or a patient that's actually thrown a PE? Majority of the folks are like, none, 1, 2, maybe. Right.
Yeah.
So
like a symptomatic DVT is, I would say, pretty rare. And we'll get into that later on, but yeah, it's just not they don't really become symptomatic a lot of times.
Yeah. And a DVT is probably staring us in the face all the time. We just don't see it because it's not symptomatic, especially if you have an older individual who was in the hospital. And we'll talk about kind of some screening tools that you can use to kind of see what the risk factors are. But, just being 61 to 74 years old, you're on a screening tool, you've already got 2 points up against you, and that puts you at low risk. If you move into 3 to 4 points, then you get into moderate risk. So, if you add surgery to that, you just added 2 more points. So you went into a moderate risk of at least having a potential DVT. Again, that's the thing though, is a DVT isn't really an issue until it becomes a PE. Then we got a problem, this pulmonary embolism, and that's what kills people. So what we're really want to look at is these things might be here, or if they're not there, are we making them occur because of blood flow restriction? And then I guess the most kind of prescient thing is the post-surgical patient. It seems like it goes up quite a bit. What did you say, Kyle, earlier? 100-fold? I think someone said that. I might have it here. It goes up 100-fold post-surgical. And the highest risk is the first 6 weeks after surgery. So that's when blood flow restriction is supposed to be done, is the early acute phases. We think that's where it has the biggest bang for its buck because you can't lift heavy during those phases. And that's when we want to start blood flow restriction. Any thoughts or things you want to add on what y'all seen on incidence rates or risks?
I think that number that you mentioned comes from a paper by Sweetland, one that I think I sent to everybody, and it was a huge sample size. I mean, it was mainly geared toward middle-aged women in the UK, but their sample was like 947,000 plus. So it was close to 1 million women that they tracked over a few years time span. And the number that I saw that kind of stuck with me was if they had an inpatient surgery where they're going to be staying in the hospital for a little bit, they had a 70 times higher risk for having a VTE in the first 6 weeks after surgery. If it was an outpatient procedure, it was a 10 times higher risk during the first 6 weeks. So essentially it was like the first 12 weeks post-surgically, there was a higher risk. Beyond that, it seemed to really taper off, but the highest risk was, really within that first 6 weeks, which you mentioned is kind of prime time for BFR to really have the best effect to stave off a lot of these things we talk about all the time.
Right.
Right. So it's really that increased risk. Is it really something that we're going to see, like we've talked about, a symptomatic, clot during that time period? Obviously it's possible, but seems like maybe from what we see clinically, not as common. Yeah.
And again, if you look at the rehab world, how many people screen for it? Other than you just look, is it hot, swollen, anything that's just staring you in the face. But we're not taught to look for these in school, and we don't screen for them. Primarily, again, because, it just didn't seem like the incidence was that high, but it does look like there is a potential high incidence. So just doing heavy exercise or whatever with that patient, there could be something lingering there. So people do have to be aware of it. I think one of the things I took out of one of the papers, approximately 50% of patients who develop a clinically diagnosed VTE will have 3 or more acquired risk factors present at the time of diagnosis. And these primarily are 48 hours of immobility in the preceding month. They've been in the hospital, they've had surgery, they have a malignancy, or they have an infection within the past 3 months. So those are kind of the key factors for getting not a hereditary factor, but you've got a clinically kind of based factor that brought this on to you. So with the BFR literature, we can do this, and we do this in our course, and there's this big sweep that you can say, like, okay, how many reported clotting events have we seen in the literature, which is really one case study. And it was, we can go into that case study, and it's a really kind of screwed up case. The totality of the literature, there's really nothing. How many reported BFR clots have we had, reported to us at least, who probably are seeing the most BFR right now done clinically? I haven't seen any come across us, none come across our medical device manufacturer. And so if you're looking at those two things and you're like, well, we're not really seeing it kind of from this big 10,000 foot view, but then what has exactly been studied and looked at it? So people always reference these survey studies that were done. And on these survey studies, how many people have reported a clot to the person being surveyed. And so one of those survey studies is pretty good. And it was done, and I was part of the people they surveyed. Stephen Patterson and Chris Bradner did it. They actually asked clinicians, just report these things to us. The one that gets cited a lot is probably the worst one. And it's the one that was done in Japan, where they asked fitness professionals, basically, just tell us what you've seen over time by doing blood flow restriction in a fitness type setting. I'm not sure how many people who are personal trainers or in a fitness setting are having patients, they were reporting things like, oh, there was a 0.01% increase in increased intracranial pressure. Okay. Where did you get that from, man? It was like I forgot how many years they went back and looked at it. Anyways, that being said, their incidence rate from that one, which looked at, a lot of people they surveyed, was less than the incidence of a clot in the general population for the people that had done BFR. So that was kind of one that a lot of people just kind of said, well, yeah, see, it's less than the general population with this, but that's not good science. That's a poorly done survey. But once again, that's one way that we've looked at it. Do you guys have any other thoughts before we start kind of getting deeper into what the actual BFR literature says and what we know from the physiological mechanisms, at least on incidence or risk or things like that?
Yeah, I would say there's been a couple studies that have looked either at this acutely or over a training period, and we just really haven't seen any of the markers elevated that would lead us to believe that we're going to potentially increase the risk. And in fact, I'm sure we'll get to it, but one of the things that you see just with tourniquets in general, whether that be in the OR or with BFR exercise, is this increase in tissue plasminogen activator. And that's one of the big things that you see even in the OR is, we see this substantial or significant decrease in blood loss during the surgery, but the group that has a tourniquet on actually has a significant increase in blood loss in the drains following the surgery. And they really think it's a result of this increase in TPA, which would basically break up the clot. So all in all, like when you read those systematic reviews and whatnot, the total blood loss during the surgery is about the same.
Right.
So, yeah.
Yeah. So, I mean, we can just jump into that. What we've seen from all the studies that have measured for blood markers of clotting, none of them have shown any signs of clotting, right?
Yeah, either acutely or throughout a training period.
Yeah. So acutely means that you did it one time and they measured blood pre and post, and none of the markers for coagulation increased. Or chronically means that they've done BFR for weeks and measured blood markers for coagulation and they didn't increase. So that's already, okay, great. That's great information to know. And you know what that jibes with? The tourniquet literature. The tourniquet literature also hasn't shown an independent relationship to tourniquets causing clots. That's the thing. People always think it's, the tourniquet's causing a clot. It's these things I just mentioned, stasis, your age. Do you have a history of clots? Did you have a surgery? Did you have vascular damage? Did you break a bone and have potential increase in clotting factors from that? And then TPA is the next one. So TPA is basically liquid plumber. And it's what helps break down clots in your body. And TPA significantly goes up in pretty much every study I think I've ever seen that's try and measure it. There's quite a few, right? What I want to do then is kind of start going into I think here's the best papers for this right now. The JOSPT paper from Kyle Hackney's group, who's at North Dakota State. Kyle Hackney did BFR work when he was a postdoc at NASA. He's a friend of ours. He's still doing BFR work and some of the studies that we're helping with him support up there. Colin Bond is a lead author. They had an orthopedic surgeon on there, Dr. Noonan. who's the team physician for North Dakota State. This paper in JOSPT is probably one of the best reviews that I've seen on this, and really goes deep into explaining the mechanisms. We'll put a link to the paper in our show notes. And so if you're like, I want one good go-to source, I think that's a good one. We have our position stand paper, and I wrote the VTE and the potential for clotting with BFR. I was the lead on that section. It was one of them I wrote. I think the JOSPT paper, Colin Bond's paper, is better than mine. I'm kind of embarrassed now to read mine after. I was like, man, I should have like stepped my game up, man. But I had multiple sections I was dealing with. And then our techniques in orthopedics, which we can also link to. Chris Bradner out of Aspetar wrote a safety section and really did a good little nice summary of potential clots and issues that can go with that. So here's what I'm going to kind of read some quotes from the JOSPT paper. And here's what I like about it is they said, they broke down what you said, Zach. This is what the BFR paper said as far as what we know from clotting, and as far as what we know from TPA. It doesn't look like that's an issue. But we don't have this like just epidemiologic paper that's tracked all these BFR, sessions and what's the incidence rate. So we don't have an incidence rate of clotting. As far as we know, it's pretty much almost zero from what we've seen, but no one's published that data. So then what they did is they said, well, then let's go into the mechanisms that cause clotting. And so I had to look up, because I've never known how to say this word, Virchow triad. It's spelled VIRCHOW. We were taught it in school. We've all been calling it Virchow. But go Google Scholar, how do you say Virchow in German? Because it's a German physiologist. And it's Virchow. Okay, so everybody learned something from this today.
I think it's got to be fear at the front, because V in German is going to be an F sound, right?
Really? Are you serious?
VW is Falve. I mean, I'm just saying.
It's VI.
I know that, but
Ben, you were holding on to this little nugget until we got on the podcast.
Yeah,
like we went all through this in the pre-lead up, and you just held that out. You were waiting.
Why wouldn't I?
I worked my ass off. Pronunciations of this today.
Johnny's like looking for, some sort of Rosetta Stone before we get on here, trying to figure out how to pronounce this, and you knew all along.
For today's podcast, it's Virchow. All right. So I'll get Alex Franz or someone over in Germany that we work with.
I'm still going to say Virchow. I mean, that just makes it easier.
It looks like Virchow. But here's Virchow. Basically, okay, so he's an old German who came up with the mechanisms. It's a triad of like, these are the mechanisms that would cause a clot. And so there was some debate, and did he actually really come up with it? And it's been kind of redefined over time. But basically it's this: stasis, endothelial injury, and hypercoagulability. I can't freaking talk today. Those are the triad. So if you're increasing those, then you're increasing the potential to have a clot. Okay, so then we can go deep dive. Does BFR start to increase any of these triad factors here? All right, so the first one, stasis. Let me read a quote. There's no doubt that BFR causes a temporary partial restriction of blood flow. Indeed, the goal of this modality is to initiate hypoxia and metabolic stress by limiting arterial inflow of oxygenated blood and venous outflow of blood-containing metabolites. Most individuals associate stasis with tourniquets, such as those used in the operating room or the battlefield to prevent significant blood loss and save a life. Although the acute use of a tourniquet in the absence of other factors is not necessarily associated with VTE. So what they're saying there is, okay, we're not talking about stasis that I'm laying around. We're talking about stasis that I'm blocking the blood, all right? Most people say a tourniquet used in the operating room creates stasis and thus causes a clot. Although when you look at the literature, it pretty much states that is not a producer of a clot, right? I fumbled around that. Anything y'all want to add to that?
Yeah, I think one of the important things that, that bond paper went on to say right afterward is BFR from a stasis standpoint is typically done with exercise, right? So you typically have movement, you have the muscle pump, you have all these other things along with that, temporary restriction of blood flow that isn't necessarily causing stasis that further kind of protects us with BFR.
And that's where BFR, if tourniquets in themselves aren't even causing the stasis and the clots, the next quote, exactly, Ben, BFR cuff inflation pressure is typically between 40 and 80% of limb occlusion pressure, which allows for some blood flow to be maintained. This is way lower than the 300 millimeters of mercury routinely used in the operating rooms for lower extremity surgeries. So we're not even causing close to the stasis pressures, right? The full occlusion pressures that they do in surgeries.
Correct.
Furthermore, using a standard set of reps and that are prescribed for BFR, basically when we put on a position stand, you're typically only going to be under cuff inflation for about 5 to 10 minutes, right? They did state you might do additional exercises, but the cuff will be deflated between them. That's an important point there. These dummies out there who are like, yeah, just keep the cuff on while you do 5, 6, 7 different exercises. Well, then you are increasing your stasis. But with BFR, again, we're typically, it's about a 6-minute bout if you're doing a strength exercise with it. So that's way less. The tourniquet timeout time is 2 hours, right?
Yep.
And that's not because of the stasis. That's because of the reperfusion.
Reperfusion, ischemic injury.
Right.
It's not stasis. It's the ischemic injury.
Yeah.
That's exactly it.
I think the key too is like all these cases where they talk about stasis, the examples that they give are atherosclerosis. So there's pooling of the blood. It's these prolonged exposures to stasis, not these intermittent exposures. I mean, if anything, BFRs, you could argue that it would assist in limiting stasis, whether it be the tourniquet, the IPC or BFR, et cetera. It's a manipulation of what's happening within the limb. So,
yeah, I think they hit on that in that paper as well. And then you also get, I mean, with the IPC, even when it's passive, and if you do go to full occlusion for say 5 minutes, you get these vasodilating effects with that as well.
Right.
And potentially that could help move blood flow into and out of the limb, just as what you described, Kyle.
Yeah.
I have to dumb this way down in my head. Like, let me tell y'all what I say. Here we go. Let me bring us back down to earth here a little bit.
Stop using medical terms.
Yeah, like these multi-syllabic words, I can't handle them. But I just think that it doesn't make a ton of sense that the human body would try not to survive. Like if you expose it to a stimulus that is potentially deadly if prolonged, it makes no sense that the body's response, once you remove that stressor, that it would release things that would make that situation worse. It's just like you don't see the human body do that with regard to anything. I walk outside to go to my truck in the California sun, and I don't have a cap on. I get a little bit sunburned on the top of my head because I'm basically an albino and bald, and that is my body's response to try not to die. Because if I stayed out in the sun all this time, I would die. And we just see it with so many different stressors that I think like I have to kind of dumb it down in my head. Like, oh, this is just my body trying to not die is all it is.
Yeah. But this isn't even that bad of a stress, what we're talking about with BFR.
Right.
And I like that IPC scenario, kind of analogy they use. So intermittent pneumatic compression, you go in the hospital, they basically put tourniquets on, the big, long, pumpy things to start pumping your blood back and forth to do 2 things, to increase the muscle pump and also what you mentioned, Zach, to get the NO cascade going. So basically, when blood is pushed back and forth through the reperfusion, that nitric oxide will get released, and that causes vasodilation, which is exactly what we're doing with BFR, and that's that increase in NO that we see, right?
Yeah, and think it's important, that paper, I got a little confused at first when I was reading it with IPC being thrown around, that, they were talking about intermittent pneumatic compression as opposed to ischemic preconditioning, which,
I know.
Very, very different thoughts there,
too,
but
yeah.
kind of, similar in some ways as far as this kind of inflation deflation going on.
Yeah, they mentioned it later on in the paper, and I was thinking IPC the whole time, ischemic preconditioning, and so I was like, well, I don't think that's true. And I was like, oh yeah, intermittent pneumatic compression.
Yeah.
It's a good analogy.
Yeah.
It really is. And then what the muscle pump thing is very interesting, because the muscle pump's the main thing that we're looking at. So when you're doing BFR, you're using low occlusive pressures. You're allowing blood flow to go in, and the patients are typically moving. Even our self-swelling protocols, we're still having patients do isometrics or e-stim or ankle pumps or something. I mean, it's very rare that we're telling people to just lay there and do nothing with it on from a self-swelling protocol. And so they preach our Bible in this, and everything they use in there is exactly what we've been teaching forever. That one additional benefit of using a wider cuff is that it encompasses a larger volume of soft tissue other than the lower required pressure. And then other than the lower required pressures from using that wider cuff, it's these mechanical and biomechanical benefits that may be greater than a narrow cuff. So basically the wider cuff's almost even more like intermittent pneumatic compression, that you're getting this kind of muscle pumping effect. And while the compressive stimulus of the cuff during BFR is not as repetitive as that during IPC, it's plausible that combining the effects of a single compressive force from the BFR cuff with the cyclic nature of the muscle contractions during resistance exercise may enhance the ejection of blood from the vasculature of the lower extremity after cuff deflation. To this effect, some evidence suggests that BFR facilitates a chronic enhancements in vascular function and blood flow compared to just low intensity training alone. So we're probably even helping the vasculature when we do it. Anything else y'all can think on stasis? If stasis is the main concern with a tourniquet, and if you're looking at it from that perspective, I think stasis is the easiest one to say, well, these are all the reasons why we're not creating stasis and we're being beneficial.
Yeah, it seems to be the most modifiable of those risk factors as well. Hopefully people are getting education on why they need to move after surgery, and hopefully not too much of the physician-imposed or self-imposed restriction of movement happening after surgery.
Right.
I'm not
other
finding
issue
it right
is
now,
endothelial injury.
Yeah. Okay. So I think you're headed down that road, Johnny. That was one of the. I felt like the bond paper addressed that at some point, like talking about, is there a contribution of the tourniquet to like an endothelial injury, which I thought was an interesting connection to draw. Not something that I felt like I had heard anybody do. That pressure from that, if it's spread over a wide region and it's controlled versus a narrow area, that potentially might lead to some sort of endothelial injury.
So that they were saying that a narrow would be better from an endothelial injury perspective?
Oh no, I meant worse. No, like a wide contour, controlled would be better from that perspective.
Well, so that you're exactly right, and I think I pulled a quote from it. So the big thing with endothelial injury first is why it would cause a clot. So with almost any surgery, there's going to be some sort of vessel injury. The bigger surgeries, the bigger trauma, the worse vessel injury. And those are how the clots rise in those groups. So there's a higher incidence of total knee and total hip clots. And it's not just age, it's also because those are big surgeries with retraction that cause vascular injury. When you have a vascular injury, the first thing your body does is it starts to form a clot to heal itself. And so then you've got a clot that's formed and you've got a greater incidence of a VTE event happening. Even arthroscopic surgeries, there's going to be some mild vessel injury. The problem too is that when you have a tourniquet on for several hours at full occlusion, then you start to get ischemic cell death, and all those factors with ischemia, whenever you unleash the tourniquet and you get a reperfusion, that causes endothelial stress and endothelial damage on the cell wall, And that damage also is known to lead to clotting. So those are the endothelial kind of factors that we have to take into effect. So what do you guys, after reading through the different studies on that, what are your thoughts on the endothelial injury?
Like you mentioned earlier, with fractures, with any kind of surgery, there's going to be some sort of endothelial injury there, at least keeping it in mind as far as the risk. But again, it seems like for this to be problematic or symptomatic, we're going to have something kind of staring us in the face, showing that there's something going on, whether that's unexplained swelling, pain, redness, warmth, something along those lines, kind of leading us to believe that there's a DVT or VTE there. But it seems like, for most people on the orthopedic side, there's going to be some sort of endothelial injury there.
Right. 100%. Yeah. And so just taking more kind of quotes that they mentioned on this is going back to what you said, Kyle. Nevertheless, the controlled use of a wide, partially occluding cuff. So basically make sure you personalize it to the patient, which is they're preaching our language again. During a proper prescription of BFR, luckily would only increase the risk of endothelial damage slightly above a trivial risk that's already associated with traditional resistance exercise.
Yeah, and then I was just going to say the one relatively long-term training study was the 10-week study in the elderly population, where one did HIIT and then the other one did low intensity BFR exercise, and you actually see an adverse change in arterial compliance in the group who did HIIT versus no change in arterial compliance in the BFR group. So, from there, it doesn't look like we're doing vascular damage. And then you can take a look from a marker standpoint when you look at reactive oxygen species and this change in oxidative stress within the system. We don't see that upregulated, whether that's 5 sets of an exercise to failure immediately after that, nor do we see it elevated at any time point. And that specific study that did that, and when they measured that, there was no difference whether we had a cuff on and did that exercise or did it under free flow conditions at a low intensity. So, all in all, the data that we have indicates that we're really not causing a vascular insult. And then over a long-term training period, we don't get that adverse stiffening of the artery either.
Right. Yeah. So beautiful, especially for our elderly patient. But yeah, that's a great point. Looking at all the reactive oxygen species, kind of totality of literature, it doesn't look like BFR increases it. So we're probably not putting endothelial stress. The other thing, that they did mention in this paper, there's a lot of clinical trials going on right now. And so far, no adverse events have been reported. One of the big populations with this is our femur fracture trial, because a femur fracture is it's a very high energy. And to break a long bone, that high energy, you get all sorts of vascular damage as well. I think we're 178 patients into it, and we haven't had one reported adverse event as far as a VTE. We haven't had a reported adverse event anything other than patients saying BFR is hard as hell, and trying to get the damn patients to come in for all their treatments. But haven't seen anything in a high energy lower extremity trauma model as well. So from causing stress to the vascular system, I don't feel there's any concern. So that's 2 of the CALS triad that we're not having to worry about: stasis and endothelial. The other one is hypercoagulability. And so that is basically the increase in blood clotting that you get typically from hereditary factors. So this is where we got to go into it, because we've been asked this question multiple times. Things like factor V. And so I know there's quite a few papers that everyone kind of read up on before this. Can you guys go into what factor V is, or maybe what some of these coagulatable, I'm going to fucking give up talking today. Things.
There goes the rating.
I know, damn it. So go into factor V at least, and kind of what this is. So these are the hereditary. I've got a condition that makes me get clots, or I get hypercoagulable. I get an increase in blood products.
So I guess I'll jump in, and then You guys come in. So factor V is kind of the most common one. It's thought to impact about 5% of the U.S. population. And in general, there's two different ways you can have this mutation of factor V. So there's, I think I have this right. There's a factor V deficiency, which is like the opposite of a factor V mutation, or factor V mutation will also be called factor V Leiden. And that's the one that increases your risk for clotting. If you are heterozygous for that, meaning that one gene has this mutation and the other does not, then that increases your risk about 5 to 7-fold. If you're homozygous for it, essentially meaning that both parents have this gene and it's going to be transferred to you, then your risk for clot goes up 80-fold. And so it's thought that you will at least have one clot within your lifetime if you are homozygous for this factor V mutation. There's a lot of debate within all the different papers that we pulled in terms of should you test for it, should you not. In general, the opinion I felt like I was seeing over and over was that you shouldn't really be tested for it unless you've had if like say both parents definitely have it, and if after an injury or going into surgery, there wasn't like a prophylactic reason to very often that you should really be tested for that. It does look like if you have that factor V, that your risk for a clot goes up exponentially after an injury, which of course would also be tied to surgery. So I think, on our side, we might even go so far as to say, and you guys please jump in here if I'm overstepping, but if someone, even if you know someone's heterozygous for this, not homozygous, the really nasty one, but heterozygous for this, and they have an injury and a surgery, it probably makes a lot of sense to not do BFR on that person, because it sure looks like the risk for a clot really, really does go up. The others within that hypercoagulability group of things are prothrombin mutation, protein C deficiency, protein S deficiency, and antithrombin deficiency, and all of those have a substantially lower incidence in the population. But that kind of sums up the hypercoagulability genetically inherited things that persons may have that could increase their risk for forming a clot.
Yeah, and we all came pretty much to a consensus with everyone we could talk to that was smart at this, the tourniquet experts. If you're factor V, you're probably not a great candidate, especially if you're factor V and you're going to rehab because you had a surgery. Just because we don't know right now, and they've just got an increased risk. So on Vical's triad, they are actually that one's we can't control that. They're hypercoagulable. They're up. They're a risk.
So, Kyle, it's interesting that you talked about the need for testing. Someone at the last course that I taught in Indiana, actually, I guess her dad had a clot after a surgery or an injury, and so they tested the whole family because he was factor V. Had a factor V Leiden, so they tested the whole family. Turned out, basically the whole family had factor V. So she found out that way because of an incident with her dad.
That sounds like first world #America right there.
Yeah,
throw a test at everyone.
First world problems. So, but yeah, it was interesting to hear that. So yeah, I'm on board with y'all. If somebody has factor V, we know about it. Maybe not the best candidate, especially after an injury or surgery.
Still, that incidence rate is really low.
Yeah.
So luckily, most of us, the majority of your patients aren't going to be factor V. Factor Vers.
And I think if you like someone comes in like that and they've been tested for it, but no history of it, whatever you're treating them for is not something that you're really worried about it causing some kind of it may have caused some sort of vascular injury, then I think I would probably be okay moving forward and doing BFR in that particular instance. A 5 to 7-fold increase, we get that at minimum with surgery, it looks like. If not substantially greater with surgery. So,
right. Yeah. So that's where you would use this risk assessment tool, maybe.
Exactly.
To help you understand what it is. They did touch, going back to the GOSPT paper, of how IPC does decrease that risk. So intermittent pneumatic compression. During IPC, the rapid stretch on the lumen from the accelerated blood and the increase in stress due to the increased blood flow velocity catalyzes several biomechanical responses. And these responses, they're not local. So because the biochemicals enter circulation, it has a positive systemic effect. So for example, IPC done on the arm has been shown to effectively reduce the incidence of DVT in the legs. So from a hypercoagulable standpoint, not factor fives, but just from decreasing hypercoagulability, this is probably where we're getting the TPA thing. And you're decreasing this part of the triad by increasing TPA, liquid plumber. So from the triad, the only thing we've worried about so far is hereditary. You have a disease that makes your blood clot and you can't control it. So other than that, I don't see any part of this triad from a physiological perspective where we would be concerned with blood flow restriction. Right?
Agreed.
Yeah, and we're not worried about that hypercoagulability as a standalone. It's got to be coupled with something.
Hereditary, yeah.
Yeah.
But even if it is a standalone, probably the systemic increase that we get of decreasing hypercoagulability through things like TPA, even reduce that. So it has almost even a positive effect. I think you mentioned it in our notes prior to this, Kyle. It's almost like this net protein balance where muscle protein synthesis and muscle protein breakdown. If you look at this, your body's always clotting and breaking down clots, always clotting and breaking down clots. So you want to reduce clotting. Like, it's not you want to clot. I mean, that's part of healing and part of life, but you want to reduce the chance of getting clots during periods of stasis and periods of surgery. And it looks like BFR pushes that pendulum more to, okay, we're reducing the incidence of this overall, right? The one thing, Zach, and you're more versed on all this, is because I think you take them, is contraceptives.
Occasionally. Yeah.
So am I doing this right, Zach?
Do you want to go in though? That's a question that we don't.
It comes up a lot. I mean, it comes up a fair amount.
Yeah. So go into what we know about that from contraceptions, and is it safe to do blood flow restriction from what you think?
Yeah. So, when we take a look at contraceptives, there's just this natural increase risk of clotting. What we see is individuals taking contraceptives, it's between, 8 to 10 per 10,000 woman years is the kind of incidence of a VTE amongst that population. And when you start teasing out different types of contraceptives, the rate changes. And so second generation, which uses different hormones, there's a significantly lower incidence or risk of a VTE. So it's, a relative risk of 2.8 compared to the third generation contraceptives, which is a 3.8.
What's primarily used, second or third, or is it just physician?
Well, I think it's, whatever the physician recommends, and then whatever the patient or the individual likes, because I think that it's the different hormone profiles, and I may have to consult with someone else because I'm not quite as well versed as others, but there's side effects with contraceptives aside from clotting, such as like headaches, I think, are big ones, and things like that. But yeah,
an 8 to 10 per 10,000 woman years is essentially the incidence rate that we had for clot in general. Yeah,
it'd actually be lower.
It might even be lower. Yeah.
So, but yeah, so and the guidance that we typically give when that question comes up is, there's an increased risk, but again, when you take a look, have we ever seen an individual or individuals taking a contraceptive and then doing BFR or throwing a clot we just haven't seen it.
Right.
So
should we talk about that one case report? Since we haven't really addressed it, the one case that you can find in the literature, if you look at all the literature, and that was an individual over in Japan, instructor for Katsu that was, sounds like doing upper extremity bilateral 3 times a week for 2 years and doing 30-minute to hour inflations per session, but had a history of having some kind of diffuse swelling at the collarbone on the left side and some pain and tenderness there for 6 years prior to the VTE event. So they went on to say thoracic outlet Paget-Schroeder. So it sounds like there was significant restriction there. Mm-hmm. And it would be really hard to say that BFR is what caused this clot to happen.
Yeah.
Sounds like upper extremity is less common than lower extremity. And you've got this, thoracic outlet Paget-Schroeder combination that would increase your risk significantly. And it's 2 years into doing this very chronically. And even though it doesn't match up with guidelines for application for what we would say, position stand, this is best practices, it would be really hard for someone to say BFR is what caused it.
Yeah. Agree. And the, person was a total dummy. That was Darwin also kicking in, 2 year, who wants to do BFR for 2 years straight for an hour at a time? So yeah, I'm sure it was, these other TOS things that could create that. And that's something to mention too. It's a good point, Ben. The upper extremity is much more rare. I know when I was researching and talking to some experts, I think it's a 10% incidence rate in the upper extremity. And it's primarily folks that had central lines or PICC lines in. So if you do have a patient that has a central line or had a central line, you would want to talk to the medical team just in general, because they're the ones that have the highest risk apparently of the upper extremity VTE. All right.
Yeah, so, I think, I wouldn't even call what that person was doing BFR. To me, that was exercise really without a purpose. And I don't know why you would be strapping a cuff on yourself and doing that. You might as well just go to the gym and exercise and do something. To me, BFR, just like any exercise, at least we prescribe in clinic, it ought to be addressing some sort of a deficiency where you can't lift heavy for it. If you can lift heavy or even moderate for it, then I don't know why on earth you're strapping a cuff on yourself and doing it.
So. Yeah, a thin narrow cuff as well. She was using a Katsu device, which again kind of goes against our guidelines. The other group too, I don't want to forget about it, is pregnancy. They are at an increased risk. I didn't really read. There's not really any BFR in pregnancy, but what did you guys see on that? It's just from the increased pressure, right, from the baby.
Yeah, there's a natural increased risk to throw a clot, or to develop a clot, I should say. Postpartum, it increases 5 times compared to actually during pregnancy. And then the risk ratio is a little over or almost 4.3 during pregnancy and postpartum to develop a clot. So
what does risk ratio mean, Zach? Will you explain that? Because you gotta dumb it down for me, man. Come on.
So basically you look at a risk ratio of 1 means there's no risk. So everyone's the same. And then as it goes up in decimals, so like 1.3 is a 30% increased risk. And then from there it just goes. So it's a relatively higher risk to develop a clot if you're pregnant.
More than about a 4-fold risk, it sounds like. 4 to 5-fold risk increase.
So,
but why would it go up postpartum when the pressure's off?
I would think damage
because of all the bleeding, all the. I mean, Johnny, you're a dad.
Oh, the clotting. Yeah. Okay.
Damage.
Yeah.
I didn't go into that room, man. It scared me. I was freaked out. So I kept my eyes closed and was crying in the corner the whole time.
That's the only thing I remember is they're just like, if you see like a lot of red blood in the commode, just call the nurse.
Terrible. It's terrible. Okay. And that's what we've pretty much always said too. If you're pregnant, let alone we don't know anything that would happen to the fetus. So, it's because we don't know, and Lord knows there's probably never going to be a BFR pregnancy study.
Right.
If we're pregnant, we basically say we don't know, and there's an increased clotting risk in general. So let's just not do it on this person. Unlike a BFR in quotation expert that spoke at a conference with me on my panel, a freaking knucklehead who said it's perfectly fine on pregnant women. He sees no problems at all. Go for it. But he also advocated using it for an hour at a time while swimming in the ocean. So careful with what people are saying out there.
It's the 20-minute rule. I've heard about this 20-minute rule. It's like the magic number. As long as you exercise for 20 minutes, all the good stuff happens.
Oh, all right. Well,
it has nothing to do with exercise prescription, Johnny. I don't know.
Just 20 minutes.
Yeah, it's just 20 minutes of, do stuff. Get on, flip one Bosu ball one way, the other way, strap some bands on, play Tickle Monster, and go cuff, and you're good.
Right.
Yeah.
Systemic. Yes.
Systemic.
Well, and any other from Vical's triad or any other groups that we want to mention that these are groups we wouldn't probably do it on right now? Again, if you got a question, always discuss with the medical team and the patient, but anything else that I'm missing that you guys can think of?
I think we covered it. And just on the positive side of things for us, I think the paper that we didn't really discuss that would be worth talking about is y'all's paper DOD post arthroscopy starting at week 2 going to week 6. So Tennant, lead author, BFR versus control post arthroscopy, and bilateral ultrasounds on everyone in the study, whether they're BFR or control. Nothing to be found in this high risk period post surgically doing BFR multiple times per week for multiple weeks, for basically 2/3 of this high risk's first 6 weeks.
Yeah. So I think there was mentioned in that GOSPT, there's been no blood marker studies that looked at DVT or VTE, but there is ours where we used imaging. So there is a post-surgical imaging study which saw no incidents at all, and it's been done on healthies if you're looking from the blood marker perspective, and folks with cardiovascular disease, and those blood markers didn't show any signs of coagulation as well. But and this was in that paper, if a VTE event is suspected, then BFR should not be prescribed for the patient. And I think we would all agree with that, right? Your patient walks in and I got a clot, I'm not going to do it. The magic question we always get is, when can they start? Clot's cleared, I'm off prophylaxis. The problem with prophylaxis is if they're on thinners, then you might increase bruising from the tourniquet. So typically we're not doing it when people are on, not always, but there is a risk of bruising. But, I had a pretty high-end NFL player where the guys of the team were asking, is it safe to start him? He had a clot after surgery. When would we allow him to start? What have y'all's general guidance been on that?
I typically tell people, if you've got somebody that's been cleared on imaging and let's say you're done with prophylaxis, maybe give it a couple weeks just to kind of monitor. It could be a standalone event. You probably would be able to tell fairly quickly, I would think, if there's going to be any kind of recurrence. And that gives you time to explore what can you do with traditional exercise for a period of time, because let's not forget, we can make exercise harder traditionally.
Yeah.
Maybe get some things there before we decide, man, I really have to have this tourniquet application for this individual.
Yep. Yeah.
Yeah, I think the key there, Ben, is like what you said. If you have access to the imaging, so if you can run a Doppler and look at it from that standpoint, then that's fine. But in my opinion, is if you don't have access to that, I just hold off. And probably during that rehab experience with them, is I would just do traditional exercise. Not that I think that I have a risk of either developing a clot, but you know what? It's just a risk reward and something that you just don't really want to be associated with, is how I look at it. But I think, like I said, the key is if you can get the image, that's fine, and that can rule things out. But if you don't have access to that in your clinic, I think finding an alternative approach is probably best.
Yeah. Yeah, and they do put out, I think this is good guidance, your ideal candidate for BFR are those who can ambulate freely, they're generally active, they don't have a known temporary or permanent condition that alters their blood flow and can perform traditional resistance exercises safely, albeit not at high intensities, should all be relatively very safe for BFR. So those are your low-hanging fruit. These other ones, you got to take them on a case-by-case basis. From the endothelial side, the ideal candidates for BFR with regard to endothelial injury are those with less traumatic injuries and invasive orthopedic surgeries, limited endothelial injury or vascular compromise, no open or unhealed soft tissue injuries, and an operative site that will not be directly underneath the cuff application site. Although in our femur trials, we're putting it right over where that operative site is, and we're not seeing any issues. But that's just general guidance there. Probably the main risk score, there's multiple out there. The Caprini risk assessment model, you can even pull up a Caprini risk assessment calculator. There's a little app for your phone. If you work in a population that you're concerned with this, and it's a point scale. So basically, if they're 41 to 60, they get 1 point. If they're over the 75 years, they're already in the 3-point category. If they've had a stroke less than a month, they're in a 5-point category. And as you start to look at all these things you take into account, did they have surgeries? Do they have cancer? Yada, yada. If they're greater than 5, they're at high risk. 3 to 4 points, moderate risk. 1 to 2, low risk. And if they're 0, they're almost no risk at all. So if you have a patient you're concerned with, run a Caprini score on them, just so you have an idea of what to talk about with the medical team. In that paper,
we'll put those in the show notes and everything so that people can just go there, and I can put all that in there, and we'll put in all our resources that we use, and maybe I might even put our outline in there just so people can kind of see what we do.
I think it'd be good. And they put possible contraindications. They had one table for blood flow restriction in regards to VTE, and it's pretty much our exact contra list that we use. It's almost like they cut and paste it. So if you've gone through our course and you use our stuff, our contra list is basically, if you're following that, you're following probably best guidance that we have right now. All right. Good paper. I want to end with a couple more quotes here, maybe one more quote. Here's their, I like the way they ended it here. The collective literature suggests that a proper prescription of BFR in the context of Virchow's triad would not heighten the risk of developing VTE. Nonetheless, clinicians need to thoroughly screen for VTE signs and symptoms and be cognizant of each patient's VTE risk factors before proceeding with BFR. Healthcare professionals must also make sure they have the proper training and are using the correct BFR equipment and pressure prescription techniques to ensure their patient's safety. And if you read the paper, the entire thing basically highlights the way we do it. Wide tapered cuff, self-regulating cuffs, et cetera, et cetera. So I feel pretty positive that we're following best guidance. I think because we help kind of set up best guidance starting out. Cool. Any other thoughts, fellas? All right.
That all sounds good.
I was going to do BFR because I'm stuck at home, and I had a bag here, and I opened it up, and I'd stuffed all my old laundry in that bag, and I'd put the unit in my luggage. So sucks. The bad news is I didn't have a unit. The good news is I found a bunch of my old underwear and stuff that was in my bag. So, and like all these, I just bought all these new vitamins, and I've been looking for them everywhere, and they were in that bag too. So, Ben, we're gonna have to disinfect that bag, I think, before we reach.
Did you find your AirPod charging case?
Yeah.
So, all right, guys, enjoy your time at home. My kids only came in twice during this call.
Nice. I threw a sandbag in front of the door over here so no one could come in. So yeah.
I even put a sign out like "Leave Daddy alone," and they're still like, "We're hungry. We can't find Mom." They used to feed themselves just fine, and now they can't freaking feed themselves these last week and a half at home. So I don't know what's happened, man. All right, thanks, guys.
All right, thank you.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.